So I'm hoping that these slides will be somewhat understandable. Well, first of all, who I am I am the medical director of Cortigen. Cortigen is a company in the Boston area that provides genetic services in terms of DNA sequencing for a variety of neurological conditions: mitochondrial disease, autism, epilepsy, and functional disease: pain, fatigue, GI problems, depression, anxiety, dysautonomia. But that's one of my roles. I'm also, I was at USC as faculty for University of Southern California faculty for 20 years in the medical school and practicing at Children's Hospital Los Angeles for those 20 years as a geneticist and as a pediatrician, and just recently in private practice in the Pasadena, California area. So I have a lot of experience in this area, and during the time at USC I did research on, particularly in the genetics of mitochondrial disease and in functional disease. Again, you're hearing about that many times: pain, fatigue, GI problems, etc. So what I'm going to do is I'm going to present some patients. These are all real patients with mitochondrial disease. I've been working in mitochondrial medicine for 20 years now. Mitochondrial disease, as if you don't already know, you'll become to understand it's extremely diverse. And the things that I'm talking about in mitochondrial disease, almost all of them apply to other rare diseases as well. So while I'm talking about mitochondrial disease, it sort of can go to other ones. But the first patient I want to talk about is Peyton. And there's her picture. I have permission from the families to talk about these patients, and when I come up with pseudonyms for them, they all get upset, these teenagers, because they can't imagine that ever being called that name. So there's a couple of cases later that I've changed things around, and I'll tell you, in those situations. But Peyton is a real patient like the other ones. I'm going to show you 4 patients with mitochondrial disease to kind of give you an idea as to what the range of them are. And unlike even 5 years ago, in which we had all of these patients with mitochondrial disease and we had really no idea what they actually had, and people didn't really understand, this is mitochondrial, this is not, or are they faking it, are they psychiatric, something like that. We have real diagnoses now. So these are patients that are proven mitochondrial disease on the DNA level recently. But they went for years and years of a disease that they didn't understand. So Peyton's the first one. She had cyclic vomiting syndrome. If you don't know what that is, it's really, really horrendous. Peyton would vomit for a week and have horrible nausea that would last for about several days, and which she was completely incapacitated. The episode would go away, and then it would come back a month later, and she'd do it again, and for years. That, at age 10, morphed into chronic daily migraine, where she had a migraine headache 24 days a year, 24 hours a day, 365 days a year. I mean, just constantly migraine. It was never gone. She also had multiple hospitalizations for bowel cleanouts because she would get obstructed. But those weren't her chief complaints. Her chief complaints was chronic fatigue syndrome. She was disabled from the chronic fatigue syndrome. She'd be in her bedroom and she'd have her laptop, and she was a good student, getting A's and B's in normal classes. But even if she came downstairs for breakfast, just interacting and doing that would wipe her out for the rest of the day. There's no way that she could ever attend school. She couldn't go to any extracurricular activities. Even having a friend over in her bedroom for an hour was taxing for her. So she was totally disabled by this disease, which was, as you can see at this point, it was not very well defined. And I brought some, let's see, where is the point? Do I have a laser pointer on here? I'm going to push every button until I find it. No, that was not the right button.
As a pilot, don't press that button.
Okay.
So it won't work on the HDMI screen. You're going to need it.
Okay, all right. I actually have to go to the screen and point. Okay. Which would be out of the camera, right? All right, okay. Technical difficulties, though, it's not. On the bottom of the screen, in purple, you can see that there are pain, fatigue, and GI symptoms. There is much more to functional disease than this, but I want to bring up what I call this triad, because this triad is common. And you can see that Peyton has this triad. Well, when we ended out sequencing thousands of genes, literally thousands of genes, we found that she has what I call the common mutation in the TRAP1 gene. TRAP1 is a chaperone. What do chaperones do? Chaperones take things where they're supposed to go and keep them from doing things they're not supposed to do on the way there. Right? A molecular chaperone does the same thing. It takes proteins where they're supposed to go, in this case within certain parts of the mitochondria, and it keeps them from illegally folding, inappropriately folding on the way there. So a chaperone takes the protein and keeps it from folding, takes it where it's supposed to go, and then forcibly folds it using the energy of ATP, sort of like a shotgun wedding. Okay? So that's what a chaperone does. It uses ATP as the energy base. This is the chaperone for antioxidant proteins. Some of you may know that in mitochondrial disease, one of the major problems is you have pro-oxidants, or things that reactive oxygen species that are made by damaged mitochondria that then attack the cells. So this is an inability to really process antioxidant proteins, or proteins that protect the cell against oxidative, and I'm trying to use the pointer again. I'm going to have to actually go to it for this. This is a TRAP1 molecule here. Okay.
Best we can do.
All right.
That's what you hold.
Okay. This is what I hold? Okay. I kind of like this one better. It's sort of the golden touch. I don't know. Okay. Here we go. Here's another TRAP1 molecule. They're exactly identical. There's just two copies. The green here is a molecule of ATP. The green here is a molecule of ATP. If you have mutations in the TRAP1 molecule that actually touch the ATP site in these three locations, and this is the location of the mutation in Peyton, it affects probably the way that ATP interacts with this molecule. I think what it does is it causes an ATP eating machine, and ATP is broken down. ATP is what energy is made as and stored in the body. But we don't know that for sure, but it definitely is affecting the antioxidant proteins. So these patients get pain, fatigue, and GI problems, as well as many other things. So using collaborators at Georgia Tech, they took the entire Georgia Tech computer system for the weekend and used it to discuss this thing. Again, sorry with the camera over there, okay, is can you design a molecule which will fit into the ATP binding site and bind only to the mutant molecule, meaning the one with the mutation, and not the wild type or the normal one? Because this is a dominant mutation. One mutation from a parent goes to a child. So that child has a normal TRAP1 from one parent and a mutant TRAP1 from the other parent. So we want a molecule that will go into the binding site and tightly bind to the mutant, presumably destroying it, keeping it from doing what it does, while keeping the wild type alone. The computer came out with Kytrel, which is a drug which is used for chemotherapy-induced nausea and vomiting. We gave Kytrel to her, and she's like completely different now. She has some fatigue, but she goes to school 80% of the time. She still doesn't take, I think, her last course. Her chronic fatigue is much, much better. Her pain is gone, and her hospitalization for a bowel clean-out in a couple of years now. So Kytrel has made a huge difference in her. So that is showing you, if you know the molecular cause of the disease, you can find some sort of therapy which is direct. Now, this is a common variant. In a lot of my patients, I have many families that I've been following for over a decade that turn out to have TRAP1 disease. This is a child who has straight autism. He had autism, which I think that, following an MMR vaccination at 1 year of age, he developed autistic features. He's now about 7 years of age, and he just has very severe autism and mental retardation. Such severe autism that the parents could never go to like a restaurant because he would run around the tables making animal noises. Very much disabling for the entire family. He has the TRAP1 mutation too. It says, well, why did you think it might cause autism? Because I have a lot of girls in my practice that have pain, fatigue, and GI problems, and their brothers with the same TRAP1 have autism. So I say, well, maybe it's somewhat related to that. Not the cause of autism, because in many cases there isn't, but a contributing factor among other factors that permit autism to develop in that child. Well, anyway, you can see on the bottom of the slide there, if you can see this at all from the back of the room. But anyway, after Kytril, he got much better. The parents can actually take him out to dinner in a restaurant. He will sit there and he will eat and he will behave. That's how much different it is. The daycare was like, what did you do with him? He's a different child. They were not told about the drug. The drug was taken off. He reverted back to his original state. It was put back on again, and he was better again. Later, of course, the pharmacy ran out of the drug, so he went off it for an entire month. That was very hard on the family. So it really is the Kytril that's doing it. It's not just that he grew out of it. The next patient is one that I've followed this family for 2 decades now. The proban had cyclic vomiting syndrome, the sister, but this is the brother. He was the mildly affected brother of a severely affected mitochondrial disease sister. He had some functional pain, fatigue, and he had a little bit of pain here and there, but he was in normal classes full-time and really a normal boy. And then he had a benign tumor on his back. It was removed and he got complex regional pain syndrome. If you don't know what complex regional pain syndrome is, it's very severe pain in terms of duration and intensity that goes for years after some injury. You can break your leg, you can have a surgical, it can be any sort of injury that precipitates that. We put him on the medications and that went away. Then he developed really bad POTS, which he would stand up and he would blank out and fall down. It got so bad he would blank out, look like seizure activity, and paramedics would bring him to the ICU. That happened a few times until the school said, we really don't want you here anymore. So it really, even though he had these episodes about once a month, it destroyed his life. He couldn't ride his bike. He couldn't even walk the street without someone holding his hand. Forget about driving someday or going diving or swimming or anything like that unless someone's right there. He even had trouble going to school. He was a very bright student, and he actually was involved in the research project in which we discovered TRAP1. He was a college student working with me, very good on the computer, and helping me going for all of these patients to say what they had. And of course, they said, we really have to test you. And he had it. And he and his family have all the things. They have pain, fatigue, and GI problems are the main problems in the family. But they also have dysautonomia, and then there's some other things in the family. So this one mutation, he has a different mutation in TRAP1. It's actually a more severe mutation. It's a mutation that doesn't change one amino acid to another, but destroys the entire protein by putting a stop codon on, which stops the protein from being made. So anyway, it explains why the disease in his family is more severe. And it's a mutation that is really clearly deleterious. There's no doubt that it would cause disease. But the thing is that one gene, TRAP1, can precipitate autism, cyclic vomiting, pain, fatigue, GI problems, all these sort of things. A single gene, and there are over 1,000 genes that make up the mitochondria, but one gene can do all of that. Next one I want to talk about is Carl. He was a young adult, was working full-time, had a girlfriend that they were going to marry that was very close together, started to develop these episodes of very severe pain when he was about 21 or so. And he would go to emergency room, and they wouldn't know what to do with him. And they would give him Dilaudid, an opiate, a narcotic, and the pain would go away, because all pain goes away when you get narcotics. But it would run out in 12 hours, and he would end up being in extraordinarily severe pain again. I've seen him during 2 of these episodes. He was on the bed in the hospital at Children's, even though he was a young adult, screaming and crying and jumping around on the bed to try to get comfortable. It was very bizarre looking. And at first it was like, I know that you're in real pain because you have abdominal migraine, but this is kind of a little bit on the bizarre side. I've seen him between episodes, and he's a completely normal, appropriate, intelligent, and articulate young man. But during the episodes, the pain is so bad that this is the way he is. He's just total. It's pretty dramatic. Carl if you're a kid, what do they say when you're doing something like this? The mom's doing it, right? Munchausen or something like that. You're psychiatric. What happens when you're a 21-year-old male? You're a drug addict. You're coming to the emergency room seeking drugs, right? It's the flip side of the coin on that. So he would have these episodes once a month. For 3 days, 3 to 5 days, he would be in severe pain. He lost his job. It's impossible to get another job because for 3 to 5 days, he would be in severe pain. And the only thing the emergency rooms would do was give him Dilaudid, because nothing else would work, and that would at least get him out of the emergency room. 12 hours later, the pain would be back. He'd be in another emergency room. He ran out of emergency rooms in a major metropolitan area that they all called him drug addicts. So we went ahead and we did the sequencing on him. And we found that there were 3 mutations in the RYR2 gene, which is the ryanodine 2 gene, which I'll get to. Put him on propranolol, which is predicted to work based upon the gene, and his disease went away entirely. Now, you say, okay, well that could be coincidental, or it could be, that maybe that it's he really is a drug addict, and he said, well, he's not going to get any drugs from Dr. Boles, so whatever. But the disease went away. A year later, he decided he was better and he didn't need to be on the drug. And the episodes came back again. And then he's run out for different reasons, mostly because of insurance issues. He's run out of drug on 3 separate occasions, and each time the disease came back. And his fiance would call me and says he's doing it again. He went off his drug and he's in episodes again. We'd put him back on. It'd take a couple months or so to kick in, and then he'd be episode 3. And this has been going on for the last 5 years now. So it really is the propranolol. On propranolol, he's completely normal. He has no such episodes. The issue is with the ryanodine 2 receptor. This is not in the mitochondria. It is a stress-induced calcium channel across the endoplasmic reticulum. Going way back to biology, remember the endoplasmic reticulum is this like spider web of stuff that goes all over the cell, okay? Does a whole lot of things. I'm not going to talk about it right now, but one of the things it does is it pumps in calcium. So the calcium's really high in it. And when something happens and the cell wants to do something, that calcium's released, and that's a switch. Because the endoplasmic reticulum's everywhere in the cell, when calcium is released, it then can make the cell do what it's going to do. Okay, and in the case of like a heart cell, it's to pump fast and to pump hard. So ryanodine 2 mutations are known to cause sudden death in patients when they get scared, literally frightened to death, or during extreme exercise. The reason is because in the normal people and everybody, norepinephrine, which is stress hormone, binds and causes calcium release through RYR2. That calcium goes into the cytoplasm, or the regular part of the cell, causes the muscle fibers to contract harder and faster. So when you see the tiger, your heart can beat faster and can beat stronger. That's exactly what you need. Okay? If you have too much calcium release, let's say that there's a mutation in RYR2, stress causes the entire endoplasmic reticulum to dump all of its calcium, the heart beats too fast, and it goes into an abnormal rhythm, and the heart, it can't pump that fast, so then you die. Okay? So it's basically what happens. But also when you meet the tiger, it needs to turn on your sympathetic nerves, it needs to turn on your brain. Time slows down, you're much more clear, everything's focused, and your whole autonomic nervous system is going on. So that's what happens during stress. In these patients, a small amount of stress, just moderate amounts of norepinephrine that patients get in a modern society every day, causes an extreme release of calcium. The same sort of thing as a fight or flight response. Like your spouse says that they want to leave you, or your child has been given a diagnosis of cancer or something like that. Something really major, like the tiger's about to eat you or your family. They go into that sort of stress every day, many times. It turns on the fight or flight response. No wonder they're very nervous people that have a lot of quote-unquote psychosomatic disease. These patients their GI system has horrible disease, because when you're under stress, your whole GI system turns down. They're under stress all the time. Even though up here, they don't think there's a problem. If someone cut them off on the freeway, no big deal. But their whole body goes into a overload. Somebody said something, gave them a face, not sure what it is, no big deal, but they go into a whole fight or flight response. Their gut turns off, they get abdominal migraine, they get cyclic vomiting, they get gastroparesis, irritable bowel. And their mitochondria are constantly flooded, because in the nerve cells, the calcium goes into the mitochondria, turns on the mitochondria, energizes the cell. So the nerve cell can fire constantly, much faster than it usually, and can repump everything. So what they get is that the mitochondria are turned on all the time. They burn themselves out. You have free radical-related damage, and they get pain and fatigue. So these patients get pain, fatigue, and GI problems. Here's some right here. Pain, fatigue, GI dysmotility. Same sort of thing. What propranolol does is propranolol blocks norepinephrine, stress hormone, from releasing calcium. So it's a direct treatment on the problem. We also give them a lot of antioxidants because they have a lot of pro-oxidant situation, and sort of a psychotherapy type thing that's saying it's not in your head, you're not crazy. It's not that you can't handle stress up here. It's that small amounts of stress up here cause your body to overreact, and you just have to become a Buddhist monk, sit on the mountaintop, and give your mantra. Okay? So you just let it, for the kids, go from Frozen. You know, just do not let it bother you. And they get that. The kids get that. You know. Margot is another one of my patients. I had been following her for a while. She had been going all over the United States to all the migraine specialists everywhere and specialists about things because she had dizziness. Not headache, but she had episodes of dizziness. It would last for days in which she was incapacitated and missed school. It got to the point that her dizziness never went away at age 12, and she couldn't even walk without someone holding her hand. Couldn't go to school, couldn't do anything extracurricular, couldn't go out with friends. But she was a bright student. She was completely incapacitated. Multiple experts through the country said it looks like migraine. She was on a bunch of migraine medications, gave her a lot of side effects. Nothing made her better. We did the same technology on her, found a RNE mutation in her, put her on propranolol, and antioxidants. Now she's in school full time. She does a lot of extracurricular activities. She was volunteering at Children's Hospital to make things up. She has a job. She does a million things. Her parents say she's making up for all those years in which she was incapacitated. See, she's about to start college soon. So she, in completely normal life. Can't talk about mitochondria without showing you what a mitochondria is, right? This is a muscle fiber. The arrow is pointing towards one of those white things, those white ovals. Those are the mitochondria. By the way, that's a normal mitochondria in a normal muscle fiber. That's what they're supposed to look like. Okay, I've given you two examples of mitochondrial disease in which we have a molecular cause of mitochondrial disease. So the second one, wait a minute, that's an endoplasmic reticulum calcium problem. So it's a channelopathy, yes. But the disease is caused by their mitochondria being overstimulated constantly by all that calcium going into it, and they go into mitochondrial failure. And you can see it biochemically. Okay? So it's a mitochondrial dysfunction or a secondary mitochondrial disease that I'll get to later. The next two I'm going to show are the type of mitochondrial disease that your doctor would recognize as mitochondrial disease. Okay, these are kind of the typical ones, the ones that everyone talks about. They're just more severe. It's not that the others are not real. They are real, and that these are real. These are real too. Okay, this is Helen. Helen has an ocular myopathy. She can't move her eyes very well. And she has ptosis, so you can see her eyelids are coming down. Pigmentary retinopathy, she's starting to go blind because her retina is starting to fall apart. She also has mild developmental delay. It's not really retarded, but had some developmental delay. Ataxia, is walking like a drunk, or a 1-year-old that's just learning to walk. It's got some muscle weakness and is really, really short. She, at 6 years of age in this slide, she's the size of a 3-year-old. So really cute, as you can see. But yes, that's neuromuscular disease. That's what people expect in mitochondrial disease. She has Kern-Sayers syndrome. This is the mitochondrial DNA. It's a circular molecule exactly like in bacterial DNA, and I'll get to that. If you cut it here, and then rejoin those together to make a smaller molecule, that is her mitochondrial DNA. You couldn't survive that way if it was an 100%. She's what's called heteroplasmic. She has normal mitochondrial DNA and deleted mitochondrial DNA together. So she has a mitochondrial DNA abnormality. Look at the bottom of the slide there. She has cyclic vomiting syndrome, exercise intolerance, severe GI dysmotility, episodic leg pain, and photophobia. It means that she needs glasses because even the lights in the doctor's office bother her eyes. Those are functional symptomatology. The severe mitochondrial patients have functional symptomatology. Often the GI problems, and a lot of you realize that, The GI problems, the dysautonomia, anxiety, depression, fatigue, can overwhelm and be the major problems of the disease. But if they have these neuromuscular, if they have mental retardation, if they're small, if they have seizures, if they have muscle weakness, etc., then the doctors recognize, oh, there's something real here. There must be real disease. But the difference between the milder ones and the severe ones is not whether they're functional or not, it's whether they have that more severe problems. Judy and Jenny here are twins, but you can see that there's a difference between it. Judy is a completely normal child in pretty much all respects. She had a little cardiomyopathy on echocardiogram only, but never had any heart failure, and is off of medications. Had a few seizures when she was earlier. Maybe a little learning disability, but she's really in normal classes doing normal schoolwork. Now she's a teenager doing normal work in high school. Pretty much a normal girl. Jenny, on the other hand, her twin, is severely mentally retarded, cannot walk without being hold a hand and with braces, can talk a few words, has had multiple seizures on medication, and she's in heart failure despite the medication, and it's getting worse. What's the difference between them? They both have Malus. It's a mutation in the mitochondrial DNA. It's in a transfer RNA. I don't want to go through all that stuff, but this is a known mitochondrial mutation. The difference between Jenny and Judy, they are identical twins, okay? Proven by DNA technology. And Jenny has less mutation than her normal. The one that's normal has more of the mutant, at least in blood and urine and a few other tissues. The difference is they had a stomach flu at 6 months of age. They didn't eat very much. But Judy, the normal one, was eating okay, and Jenny ate pretty much nothing at all. And Jenny went into a stroke. Had a stroke, lost a lot of her brain tissue, and that's what happened. But they both have the same disease essentially to the same degree, and they have a whole different background. So this is the difference between eating and not eating. This is to show you the environmental component. The difference between good medical care and bad medical care can be when you go into a hospital or something you're eating and not eating, right? And we'll get to that as we talk about some of these Munchausen cases and fictitious disorder cases in which the parents are saying, you know, my kid is fasting, my kid has trouble. This is real. This happens. I've seen it many times. There is a real risk, okay? But, you know, we're going to have to put that risk into perspective when we get into, later on during the day. This is no way that you're going to be able to see it. But the point is that mitochondrial disease can cause many different things because all are energy for everything they do. Every cell in the body needs energy. Almost everything is energy dependent. But you can see the blue is neurological, the red is muscle, and the purple can be either or both. Okay? Yes, it can affect any tissue, any cell. But nerve and muscle require more energy than the rest of it. Does anybody know what mitochondria are? Well, you can ask the Wikipedia. The Wikipedia will tell you what they are. The midichlorians, intelligent microscopic life forms that live symbiotically within the cells of all living things. And if you want a good quote, I quote Quinjon Jen. I can't pronounce it right on that. Okay. Without the midichlorians, life could not exist, and we would have no knowledge of the force. They continually speak to us, telling us the will of the force. Okay. This is This is a midichlorian from the Wikipedia site, which I have copied and pasted without their permission. This is the mitochondria from a normal patient. Well, there's some similarities there, I think. The point is that the mitochondria really are symbiotes. All life except for bacteria and some things called archaea that live in hot pools are symbiotes. What happened is that a bacteria got engulfed by an archaea. The bacteria became the mitochondria, the archaea became the rest of the cell. But in the bacteria, they became friends and they've been together ever since. That initial union is not just all animals, including humans, but all plants, fungi, even amoebas and prometiums and all that sort of thing. Algae, everything that's beyond a bacteria or an archaea was from that original meeting, and then it branched out from there. So the mitochondria are we are symbiotes of two different organisms with two different histories. So the basics. I'm not going to go through this in great detail, but you know about the nuclear DNA, you know about the chromosomes, right? 23 pair, 22 autosomes from both parents, the X and the Y. XX is a girl, XY is a boy. 22,000 genes, 3 billion base pairs. Okay? 1,013 genes from all these chromosomes, equally from both parents, go to the mitochondria. They're made outside the mitochondria and they're imported to the mitochondria. So those 1,013 genes, and that's not an exact number, it may go up by 1 or 2, but we pretty much know what's there, and they are the usual: autosomal recessive, autosomal dominant, X-linked, what you learned in school about Mendelian genetics. That's what mitochondrial disease is on the nuclear. But this is what a mitochondrial DNA looks like. That's a real picture of one. Obviously not color correct. That's an electron microscope. It's a circular piece of DNA it's almost identical to bacterial DNA. It has a bacterial DNA's genetic code, which is different than the genetic code in the nucleus. It is only 37 genes, 16,000 base pairs, and it's maternally inherited. Your mitochondrial DNA comes from your mother. It's exactly the same sequence as your mother unless there's a new mutation. All of your siblings, if they have the same mother, have the same sequence. Your mother's siblings have the same sequence. Your mother's mother has the same sequence. That's showing you maternal inheritance. The grandmother in red on the top there, her mitochondrial DNA will be passed on to all of her children, boys and girls, intact, same sequence. Her boys will not pass it on because it will be the girl, the spouse that passes it on. But her girls will pass it on to all of her children, regardless of the father. So you can see that all of the ones in red there have exactly the same mitochondrial DNA sequence. So if you have a mitochondrial DNA mutation, all the ones in red are at risk. That's the question, is at risk. They're not necessarily going to have the disease because genetics is risk. Genetics is probability. Genetics is not destiny. We're talking metabolism here. Metabolism is the breakdown of foods, fats, carbohydrates, proteins to make energy. Okay? So when we're talking about what the mitochondria does, we're talking about the bottom, we're talking about this slide. That's what it does. It makes energy. It does a lot of other things too. And it's a cartoon of the electron transport chain. I'm not going to go into it other than the fact that mitochondria really pump protons. They're electrical capacitors. When energy, they store the energy by electrical charge. That will become important when we get to some of the problems that happen. So what is mitochondrial disease? It's a genetic defect which affects the ability to make ATP. Or it can actually, we're finding more and more, it's some free radical related damage because of the abnormal electrical charge of the mitochondria. It leaks across and makes free radicals. It can be in the nuclear DNA, the chromosomes, or in the mitochondrial DNA, or both, which is what we're finding in a lot of patients. Okay, you hear the term mitochondrial dysfunction. You're going to hear that several times probably throughout the day. Mitochondrial dysfunction just means the mitochondria are not working properly. It can be because the mitochondria itself have a problem. That's a primary mitochondrial dysfunction, often called mitochondrial disease. Okay? The patient that had MELOS, the patient that had Kern-Sayer, the two severe ones, they have mitochondrial disease. Also, the TRAP1 patient has mitochondrial disease. There's something in the mitochondria that's not working right. The other patient, the one that Margot and that have defects in the calcium channel, that's secondary mitochondrial dysfunction. The problem's not in the mitochondria, it's outside of the mitochondria, but the problem impinges upon the ability of the mitochondria to work correctly. That's called secondary mitochondrial disease, or it's just often just referred to as mitochondrial dysfunction. So when we're saying mitochondrial dysfunction, you're saying the mitochondria aren't working. Not necessarily because there's something in the mitochondria, it can be something outside. That's very important. A lot of these patients that have mitochondrial disease diagnoses, really they have mitochondrial dysfunction and the primary defect is outside. But it still affects the mitochondria, and that's very important. Okay, where am I in the time? I'm a little over? Okay, because we started really late. Okay. I mean, these slides are going to be available later, but I want to show you what you've learned is the mitochondrial DNA is inherited only from the mother, that I'm usually not looking the other way on here, but the way this maybe I can look over here. No, I can't read it over there. Mitochondrial disease can affect almost any part of the body, can contribute to almost any disease, nerve muscle being more important, and most of the DNA that's in the mitochondria is from the mitochondrial DNA is important. You know your metabolic pathways, right? You don't? Okay, and this is not going to project very well. There are, in this slide here, there are a few hundred enzymes or something like that. That's the center of metabolism, by far not all of metabolism. Just kind of the center of metabolism on this slide. Metabolism is far more complicated than this. The problem is every single one of those enzymes has proteins which cause and spread or turn it off. Translational factors to take the RNA and make it into protein. Then that leave the endoplasmic reticulum, go to the Golgi apparatus, get glycosylated perhaps, add a cofactor, or a mineral like magnesium. It has to have other translational modifications. It's moved from compartment to compartment. It then has to be activated, and it has to be assembled into a complex, and it has to be anchored to where it's going to go. And then it has to be turned on by the entire machinery that decide that that complex is going to operate at that moment. Every enzyme has a huge village of proteins which are necessary to make it and maintain it and keep it operating. Proteins, and there's also proteins that destroy other proteins, and they can be overactive or something. So the point is that it's not just the enzymes, it's the whole thing. There are thousands of genes which are involved in the metabolic pathways. It is far more complicated. Okay, so how do we go about that? Well, now that we have next-gen sequencing, it's like magic. We can look at all of the genes to do all of those things at the same time. And I also show this slide because that's my daughter. And she loves her picture being shown. These are the machines that are the next generation. There's 4 of them. It's an aluminum MySeq that actually do the sequencing. It used to take like a whole room for a sequencer, and it used to do like 10,000 times slower than what we do now, literally. But what is functional disease? It's a whole new thing we're going to have to talk about. I know that's not enough time to read that, even if you could read that from where you are. It's a poem that one of my when she was 14 that she wrote. She has a sodium channelopathy causing mitochondrial disease. But I mean, functional disease is real, and it can be severe, and she's talking about chronic fatigue here. Functional disorders are what physicians have done that look at different parts of the body and they say, oh, migraine or attention deficit disorder, chronic fatigue syndrome, irritable bowel, autism, depression, et cetera, et cetera. These are some of the functional disorders that have been described. But really just parts of the elephant. There's an Indian proverb from India that says there's 3 blind men that are filling parts of the same animal. One fills the trunk, one fills the body, and one fills the tail, and they describe 3 different animals. Well, I like to think of this as 3 different doctors. One is the ENT, one is the cardiologist, and one is obviously the gastroenterologist. Examining different parts of the same person, the same patient, and calling it 3 different diseases. You know, it's cyclic vomiting, it's depression, it's migraine, it's functional abdominal pain, it's irritable bowel syndrome, it's POTS. But the patient has all of those, and many others. I'm going to go really quickly through a couple of patients here. I want to talk William, chronic pain, which is his main issue. He has some other things that are on the slide, but he really had pain behind his eyes and in his eyes was his major complaint. That's what really bothered him. He had a little bit of myopathy and some other issues. He has a mutation in the mitochondrial DNA at 14906. Not a big deal. It says, okay, 14960, sorry. Not that that matters. The thing is that his sister Izzy had complex regional pain syndrome in her ankle that was unrealized. At some point, she fell down and she twisted her ankle and she had pain, and the pain was severe and it lasted for years. How many MRIs of her ankle did they have to do? A lot of them. How many specialists did she see? A lot of them. They couldn't figure out what the pain was for, decided it was psychogenic. She has complex pre-regional pain syndrome. It's a normal thing for mitochondrial disease. It's very common. She was pretty much normal until she got she got anxiety, separation anxiety, and when she went to kindergarten. It was so bad that her mother had to be in the kindergarten class. Her mother or her father had to accompany her to the restroom every time she went to the restroom, even at home. She could not be away from her parents. She couldn't be with a teacher. She couldn't be with a grandmother. Had to be with one of her parents all the time. So it was like the mother, who's a nurse, had difficulty being in the kindergarten, every single day, all the time. Anxiety is very common in mitochondrial disease. Did the test on her. She has the same mutation as her brother. Started her on the mitochondrial cocktail. The pain went away. Started her on Zoloft, which has direct mitochondrial effects, by the way. And then her anxiety went away, and then she became a completely normal girl. I'm going to go through this really quickly. Other than the fact that she has autism, bowel disease, chronic fatigue, chronic pain. So autism plus this sort of thing, and she did this art. That's her self-portrait. She's a very talented artist. All the art in my websites and things are from her. And she has 2 mutations in the enzyme that takes one amino acid to another amino acid. It's a Krebs cycle disorder, you can say, a mitochondrial disorder, or an amino acidopathy. Long story short, we put her on alpha-ketoglutarate, and she improved dramatically in all aspects. Here are some of the things. You say, well, how do you know if there's mitochondrial disease? I have this will be on the website. Here are some of the red flags for physicians if they want to say, well, how do I say if a patient has mitochondrial disease? Not every patient with mitochondrial disease is going to have those red flags. And certainly some patients with those red flags will have other problems. But I tried to put those things together that make you should think mitochondrial and are often in that direction. And then that's the end of the talk. And if you have any other questions, particularly about DNA testing or anything else, I have an email on there. Okay?